Uh, if this would apply to perhaps a resident or someone in the imaging sciences, but more on the radiology side, I would say hold off till you're comfortable, because the first thing that your training program is really about being a physician, being a radiologist. And recently we had a circumstance where we had a person at the fellowship level who really needed to get more comfortable with the clinical scenario and spend dedicated time, get very comfortable with that aspect. If we would have that person do academic days and get distracted by research, you become an expert of nothing. So, at University of Utah, you expect people to be very comfortable with clinical questions and have a deep dive and get as much clinical experience as possible. But I would say that for everybody who walks in the door, it's almost certain that they will eventually see enough, become comfortable enough that they have additional bandwidth to actually make themselves comfortable, because now, in addition, they're clinical experts. They become comfortable at least at that clinical aspect and clinical question. And they will have a lot of experience in how to, they've observed patients with these diseases and how to address these diseases. So I think that's one relatively easier way for the clinical folks who gather a lot of clinical experience and really know what's going on. They're comfortable in their own skin and around the department clinically.
Great, thank you. I think we've gotten through the list of questions thus far. Any last minute questions out there? If not, I think we'll move on. So Dr. Minishima says, thank you so much for articulating academic radiology and career development so eloquently. Very, very appreciated. I'll second that. Thank you for your time and your expertise and sharing with us.
Well, thank you very much. This is the best part of my day, typically, these sorts of activities.
Great. Well, so we're going to transition to our emerging investigator discussions. Dr. Blumke, we'd be thrilled if you can join us for Q&A after this handful of presentations. As I mentioned, we'll transition to these. At the end of the symposium, I'll note that our 6 faculty judges will award a prize for the Top Emerging Investigator Award. And again, just like with Dr. Blumke's section, I'd invite you to type questions and using the Q&A tool. We're going to withhold the questions until all of our panelists have presented today, and then we'll have a combined session at the end to wrap up our afternoon. And so with that, we'll transition to our first emerging investigator presentation. This is from Shadi Esfahani, who is a fellow at Massachusetts General Hospital. So we'll turn it over to Dr. Esfahani.
Spectroscopy for Hello everyone, today I'm talking about the application of hyperpolarized MR spectroscopy for evaluation of treatment response in gastric cancer. As we all know, gastric cancer has very poor prognosis in advanced stages. Most of these tumors overexpress receptor tyrosine kinases such as HER2, HER3, EGFR, and that's why that RTK inhibitors are part of the first-line treatment in this type of tumor. However, patients develop resistance very quickly to this type of treatment, and the reason behind that is the baseline or upregulation of another RTK in this family called HER3 that acts differently and helps with skipping the inhibition, and the tumors basically grow back. And this is the reason that the new generation of RTK inhibitors are now in the market. There are either FDA approved or in different phases of clinical trial. They are pan-RTK inhibitors, and they reversibly inhibit the receptor tyrosine kinases. So what clinicians need is basically to identify the patients who would benefit most from this combined RTK inhibition therapy. And for that, we obviously have CT and MRI, which give us a very great anatomic information. We have FDG PET, which is great for giving information about the tumor glucose uptake, but none of these imaging methods basically give any information about the early dynamic metabolic changes in the tumors to predict response to treatment. We think that hyperpolarized MR spectroscopy can be helpful in that manner and can give us information like in a real time to evaluate the dynamic measurement of multiple metabolic processes in vivo. We all know that carbon is the backbone of many molecules in the body. Carbon-13 is an atom that its signal can be identified by MR. And we have very small amount of C13 in our body. So if we want to evaluate a molecule in the body and evaluate its behavior, we can have the C13 atom on that molecule. And basically what we need to do is that to enrich the amount of the C13 labeled carbon atoms, and then we use the dynamic nuclear polarization technique, which increases the number of spins that are aligned against the phenol, and that increases the C13 signal by more than 10,000 folds. How does it work? This is an example of a hypersense or polarizer, and we basically add the vial of the molecule with C13. We add some free radicals to it, and we put the vial in a 3 to 5 Tesla magnetic field with very low temperature of about 1 Kelvin. We use the microwave irradiation to transfer the polarization from the free radicals to the C13 atoms, and then this frozen thing needs to be thawed very quickly within a few seconds, injected within a few seconds, and then we can get the signal before it gets decayed within 1 to 2 minutes. And how are we using it in the cancer models? There is a Warburg effect in cancer that compared to the normal cells that they just grab the glucose and the glycolysis pathway happens and the cells get ATP through the TCA cycle. But in gastric cancer cells, most of the cancer cells, they basically use anaerobic glycolysis, and it means that instead of going into the TCA cycle, lactate dehydrogenase is overexpressed and converts pyruvate to lactate, and lactate becomes the major source of energy for these tumors. So in our study, we are thinking that with inhibition of the receptor tyrosine kinases irreversibly with, for example, a drug afatinib, then the pyruvate doesn't get converted to lactate that much, and it goes back into the TCA signal. And this is the way that we can evaluate the treatment response. So we are evaluating to see if we can use MR spectroscopy for evaluation of these early changes in the glycolytic metabolism in gastric cancer. And we want to see if we can use it for prediction of response, and if this method is more sensitive compared to FDG PET. So for in vitro studies, we evaluated a panel of gastric cancer cells, and we treated the cells with different doses of afatinib over time, and we chose one resistant and one sensitive cell line, and we confirmed it with cell count under microscopy and also with the Western blot analysis with the downstream pathway nodes to make sure that we have good cell lines for as resistant and as sensitive cells, and also optimal dose that can differentiate their behavior. Then we also evaluated the glycolytic enzymes in these two cell lines. We did Western blot analysis over time, and we saw that the LDHA activity level goes down in the sensitive cell line. However, this LDHA level doesn't change in the resistant cells, and also the level of GLUT transporter and also the other enzymes do not significantly change in these two types of cells. Again, this is in immunofluorescence assay that microscopy that shows the decreased level of LDHA in the sensitive compared to the resistant cells. Then we use the sensitive NCI NAD7 cells, and we injected them into the subcutaneous space of nude mice, and we imaged these mice before and 4 days after treatment with either afatinib or with vehicle to see the difference at the baseline and day 4. So FDG PET did not show any significant difference in the glucose in the FDG uptake in these tumors at the baseline and day 4 of treatment with afatinib. But with MR spectroscopic imaging, we could actually see a very nice difference between these two groups. In control group, the lactate to pyruvate ratio was not significantly changed between the two timelines, and in afatinib treated group, we could see the significant drop in the lactate signal and lactate to pyruvate ratio. Also, we confirmed the treatment response with histology and also with the tumor size evaluation over time. So we could see that MR spectroscopy is a more representative biomarker of early metabolic changes in gastric cancer. It's more sensitive compared to FDG PET. This method is translatable, and it can be used for other types of tumors as well. And we can use MR spectroscopic imaging for other metabolic evaluation of other metabolic markers that can be important in clinical management of patients. Thank you all very much.
Great. Thank you so much, Dr. Esfahani. Glad that we still have some great presence here. We've got over 80 attendees this afternoon, so I'm glad we have such good attendance here to see these great talks. So we'll move on to our next junior investigator, who will be Jessica Santana, who is a graduate student at Yale University.
Hi, I'm Jessica Santana at the Yale Interventional Oncology Lab, and today I'll be presenting my work titled Non-Invasive Molecular Imaging Allows Characterization of the Immune Response Following Hepatic Radiofrequency Ablation in a Mouse Model. We have nothing to disclose. So giving you a brief overview on hepatocellular carcinoma, as we know, this is a classical inflammation-associated carcinoma, and now is the third most common cause of cancer-related death worldwide, with the majority of patients being treated with local regional therapy as the main alternative option over surgery. However, local regional therapy demonstrates the recurrence in a significant fraction of patients, and the cause for recurrence can vary a lot. It has been suggested, for example, that the immune response to radiofrequency ablation plays a role in both off-target tumorigenic side effects as well as abscopal effects that in turn can positively impact the immune response to cancer. However, there is currently no instrument allowing for non-invasive monitoring of such immune response. Therefore, the purpose of this study is to develop non-invasive molecular imaging instruments to visualize the immune response to thermal injury following RFA. So our group has built a translational mouse model of radiofrequency ablation as a platform to develop and validate on MR-based immunoprobes for in vivo imaging of the immune response. Based on our findings, we have observed that following RFA in a normal liver, there is a strong time-dependent local infiltration of the immune cell population that orchestrates the tissue healing process. So having a specific cell population locally present at the transitional zone between the necrotic area and the normal tissue at a specific time point serves us as an in vivo platform to build and validate our dedicated immune probes. So guiding you through our experimental design, we have ablated a normal liver of a mouse, and after inducing a local inflammation and characterizing a large infiltration of a specific cell population at a specific time point, we have established dedicated gadolinium-labeled antibody that was systemically delivered in vivo to target a specific cell population observed at the chosen time point following RFA. And as a second established immunoprobe used in this study, we used a small iron oxide particles, or SPIANs. Iron particles has been largely used in the clinic as a dark contrast agent. Once delivered systemically, they are able to be phagocytosed by circulating phagocytes that once they migrate to the site of inflammation, they lead to a local deposition of iron that can be detected through MRI. So in this study, both gadolinium-labeled antibodies and SPIANs were able to be detected using a higher MRI scanner, which is a 9.4 Tesla Berker. So to the best of our knowledge, we know that RFA-induced thermal tissue injury largely contributes to a strong time-dependent innate immune response at the margins of the necrotic zone. And as our data shows, we have observed a time-dependent accumulation of CD68 macrophages in the transitional zone, especially 1 week following RFA in a normal liver. So having that in mind, we have systemically delivered SPIANs exactly 1 week post following ablation, which is the time point that we observed the largest infiltration of phagocytes and CD68 macrophages. And as we could demonstrate ex vivo, we have a local accumulation of the iron oxide particles at the transitional zone between the necrotic area and the normal liver parenchyma. And when we imaged those animals, we could see an in vivo local deposition of phagocytes at the transitional zone following RFA. So here on your left, we have a T2-weighted MRI sequence of 1 week post-ablation, 24 hours after systemic delivery of spines. And as a red path correlation, we confirmed ex vivo specific deposition of spines at the transitional zone through immunofluorescence and ex vivo Prussian blue staining. And as for our gadolinium labeled immunoprobes, we used anti-CD68 antibodies tagged with gadolinium. So after ex vivo observing a massive infiltration of CD68 macrophages in the periablational zone, we delivered gadolinium tagged CD68 systemically, and we were able to see a specific deposition of those cells in the periablational rim. So on your left, you have the picture taken seconds after ablation. Then a T1 weighted MRI 1 week post, 24 hours after systemic delivery of CD68 tagged with gadolinium. So on your right, you have an ex vivo confirmation of what was seen on MRI. And to further confirmed, we compared the baseline also with the T1 weighted MRI with pure gadolinium, and as well a T1 weighted MRI 24 hours after injection of those gadolinium labeled CD68 antibody. And as you can see, there is a specific rim of CD68 positive macrophages that can be visualized on a T1 weighted MRI sequence with our gadolinium labeled probes. We also confirmed ex vivo specific labeling of those immune cells using imaging mass cytometry. So on your left, you have a T1 weighted MRI 1 week post ablation, 24 hours after gadolinium labeled CD68 systemically delivered, where you can see a rim of the local deposition of the infiltrating cells. And on your right, we have the ex vivo confirmation of with the imaging mass cytometry of local deposition of CD68 positive macrophages in the transitional zone. So the main conclusions of this study is that both the spines and gadolinium-based molecular imaging allows for specific labeling of locally immune infiltrate. And this is a translational study with proof of principle for the feasibility of MR imaging of macrophages on 9.4 Tesla MR scanners. And as well, that non-invasive in vivo detection of the immune system can be achieved with dedicated immunoprobes. And as for future perspective and clinical application, this allows us to have a useful tool to enable in vivo study and characterization of the interplay between the tumor microenvironment and immune cell activity, as well gives us a platform to allow study of strategies for local modulation of the immune microenvironment towards immunopermissive phenotypes, and serves as a theranostic immunotherapy. So I'd like to thank you for the opportunity to present my work, as well as the Yale Biomedical Imaging Society. Thank you.
Great. Thank you so much, Jessica. That was wonderful. And so again, I would encourage people to enter any questions they have into the Q&A function in Zoom. We'll gather questions for our Q&A session at the end. Our next presenter will be Olivia Sale, who is a graduate student at the University of Western Ontario.
Hi, my name is Olivia Sale, and today I will be giving a talk called Combining Iron and Fluorine-Based MRI with Magnetic Particle Imaging to monitor the delivery of mesenchymal stem cells and the ensuing inflammation in vivo. Mesenchymal stem cells have shown promising results as a cellular therapy and have been used in many clinical trials with the goal of regenerating and restoring damaged tissues. However, cell preparation is highly variable, and so are engraftment rates. Many of the fundamental questions related to the fate of these cells remain unanswered. So were there cells administered to the correct location? How many are present over time? And this is important because cells must be present in sufficient numbers for therapeutic success. And lastly, is there an inflammatory response? If we can answer these questions in the days following stem cell administration, we could know whether patients might need a repeat dose or another intervention. And so our lab is working on cell tracking techniques where the stem cells are labeled with superparamagnetic iron oxide nanoparticles, and these labeled cells are transplanted to animal models where they can be imaged over time. And so our first objective for this project was to label stem cells with ferromoxidil, which is an already FDA-approved iron oxide agent, and then to detect these labeled cells in MRI and magnetic particle imaging. 1 million of these labeled stem cells were administered to the muscle of 10 mice in an isograft model. So the images were acquired on a 3 Tesla human MRI with a surface coil. And these images here show the lower limbs of the mice at 2 different time points. So the iron in a uniform magnetic field used for MRI creates a distortion. And so the region where labeled cells are present appears as a dark spot. But unfortunately, this is non-specific because we know that other regions in MRI can also appear dark. A major benefit of this technique, though, is that it is very sensitive. Our lab was the first in the world to detect single cells using iron-based MRI. But one other disadvantage is that we are unable to quantify the number of cells which are present, but we can estimate the number of cells by measuring the volume of this dark region. So that's what we did in these 10 mice, and what we saw is that the volume declined in all 10 mice over 12 days, which suggests that these stem cells are dying and being cleared from the transplant site. We also acquired magnetic particle imaging, or MPI, of these same mice. MPI is a very new imaging modality. There are only a few of these systems in the world. And MPI is unique because it directly detects the iron oxide nanoparticles. So these images I'm showing you are now positive contrast, and they show the density and the distribution of labeled cells. So we do rely on other imaging modalities for anatomical reference. So the MRI here can be referenced. And in these white boxes in the images shows the MPI signal, which corresponds to the iron label in stem cells. And we can see that there's no MPI signal coming from the mouse limb on the contralateral side. So overall, MPI, we can see, has better specificity compared to MRI, but there's still some background signal. And here is some MPI signal coming from the iron in the mouse feed, which is now in the digestive system. But another major advantage of MPI is the direct quantification. So we can directly measure the iron content now, which is an indicator of the number of cells present. And so you can see that there's also quite a lot less signal on day 12. And so MRI and MPI showed consistent results regarding the stem cells. We also know that local inflammation is very important to determine engraftment outcomes. And so this leads us to objective 2, which is about labeling infiltrating immune cells at the stem cell transplant sites using a perfluorocarbon agent. And then we can detect these cells with fluorine-19 MRI. This is how this works: is the fluorine agent is administered intravenously, and it is taken up by phagocytic immune cells at transplant sites. Or these fluorine labels can be taken up by the immune cells in the periphery and then recruited to the transplant site. Using the same MRI system, we've also acquired fluorine MRI, and that's just done by using the fluorine resonance frequency. So then I've overlaid that image to the anatomical proton MRI and colored the fluorine signal. So you can see that these images show the presence of labeled immune cells surrounding the transplant site. And the signal is directly related to the number of immune cells present. And we can see that between all these 10 mice, the signal is highly variable, but remain constant over 12 days. And so the level of inflammation is quite different in all these mice, but we saw no change over time. And so now I'd like to conclude by saying we've demonstrated iron-based MRI, fluorine MRI, and MPI can be used together to monitor the fate of 2 cell populations in vivo. We are the only site in North America to have both MPI and fluorine cell tracking capabilities. And these techniques right now are quite uncommon, but they're being increasingly used for this type of work. And so we're hoping that we can use these imaging techniques to confirm appropriate stem cell delivery, monitor stem cell engraftment, and also to detect and quantify the inflammation at transplant sites. And overall, this can help us to predict the outcome of stem cell therapies. I'd like to now thank the University of Utah for this opportunity to speak to you today. I'd like to thank my supervisor, Dr. Paula Foster, and co-authors on this work, Dr. Ashley Makala and Dr. Amanda Hamilton. And thanks to you for attending today.
Thank you so much, Olivia. That was fantastic. Really provocative work that's drawing on many cutting edge areas in imaging research. So next we'll move on to Nan Wang, who is a graduate student at Cedars-Sinai Health System in Los Angeles. Dr. Wang.
Hello everyone, this is Nan from UCLA and Cedars-Sinai Medical Center in Dr. Deviali's group. During my PhD, I'm mainly focused on the developing and accelerating quantitative MRI techniques. Most of my work is using multitasking framework, which is a novel and flexible framework for high-dimensional MRI. Today, it's a great honor for me to share some of our work using Q-match, multitasking technique for the evaluation of carotid atherosclerosis. Carotid atherosclerosis is a major cause of stroke, which is a leading cause of morbidity and mortality worldwide. Recent years, people have found that vulnerable plaque has higher risk to cause plaque rupture and consequent clinical events. And the plaque compensation is one of the major characteristics. Multi-contrast MRI is a very popular approach in the characterization of plaque compositions. However, most of the existing techniques are qualitative. Also, multiple scans are usually required to evaluate different compositions, which can cause misregistration. To overcome all the above-mentioned limitations, we propose the Q-match, a 5-dimensional quantitative technique. It has 3 spatial dimensions to cover the entire carotid with sufficient spatial resolution at 0.7 millimeter isotropic. It has 2 temporal dimensions, inversion recovery dimension and T2 prep dimension, to achieve multiple T1, T2 weightings and T1, T2 mappings. This is a multi-contrast, multi-parametric technique for comprehensive evaluation of carotid atherosclerosis. The sequence is a prototype flash readouts following periodic T2L preparations with different T2 prep durations. The different T2 prep durations generate different T2 weightings for T2 mapping, and the inversion recovery generates different TIs for T1 mapping. The null point of blood generates dark blood images for the vessel delineation, and the null point of the vessel generates MRA for the evaluation of vasculature. A randomized Cartesian sampling pattern were used for incoherent data acquisition. The center case baseline was acquired every 8 readouts from the training data, and the rest of the imaging length from the imaging data to determine the spatial features. In the reconstruction, the 5-dimensional images were first formed as a 3-way tensor by combining the spatial dimensions into one. Then, instead of recover the images at different time points one by one, multitasking framework handle the images as product of different factor matrices, spatial factor, inversion recovery factor, and T2 prep factor. The total degrees of freedom of factor matrices is much smaller than the original 5D images, and therefore it requires a smaller amount of data and shorter scan time. The final images contains a combination of every TS and every T2 preps. For the immune study, all of them were performed on Zhong'an Hospital in Korea, and a total of 39 patients with ultrasound confirmed carotid stenosis were recruited for the study. In the imaging session, besides Q-match, TOF, pre-contrast T1, T2, TSE, CE-MRA, and CE-PSE were also acquired for the plaque localization and identification. Since this patient cohort don't have the histology, so the conventional images were used for the plaque component identification. And following that, the T1, T2 values from QMatch were evaluated for each combination. First, I'd like to display some patient cases. The first case is a patient with a lipid-rich necrotic core. The core has a hypoenhancement on the CETSE with a ring-shaped hyper-enhanced fibrotic cap. QMatch indicates it has a lower T1, T2 values consistent with literature. Second case is a patient with intraplaque hemorrhage. The hemorrhage has a much higher signal on T1 weighted image and lower signal on T2 weighted images. QMatch indicates it has a lower T1, T2 values. The third case is a patient with a loose matrix and calcification. We can see the loose matrix has a higher T2 signal and higher T2 values on QMatch. The calcification has very low signal on all the contracts and also on QMatch. The results are consistent between conventional and QMatch and literatures. This scatter plot displays the T1 and T2 for each plaque component identified in this patient cohort. Within the 39 patients, there's a 53 plaques detected in total because the patient may have a plaque on both sides. 45 other plaques have the lipid-rich necrotic core. 7 have a loose matrix. 23 have calcification and 1 have intraplaque hemorrhage. And the T1, T2 values shows very good separation between different plaque combinations. This is the average T1, T2 values for each component, agreed with the literature results. We also performed ROC analysis, and the AOC values indicate that using T1, T2 alone or the combination of T1, T2 values to differentiate each component from all others. Result shows that the combination of T1 and T2 has the highest AOC value for the differentiation of all the plaque components. Indicates the highest accuracy. So as a conclusion, the T1 and T2 of different plaque components are consistent with the published results. Also, the combination of T1 and T2 has the best identification of plaque components. In the future, we hope to evaluate lumen stenosis and plaque area using current QMatch data. Also, we plan to perform this on large patient cohort with a histological validation. Also, we hope to test the reproducibility across different systems. At the end, I would really like to say that quantitative MRI has been really hot topic recently. I do think that for all the techniques to validate its number, to test its reproducibility, and to set a threshold for a clinical diagnosis is very important to really make all these advanced techniques into powerful clinical tools. That's all. Thank you for listening.
Thank you, Nan. That was fantastic. I think I can speak for my vessel wall collaborators that was very intriguing for us, and we'll want to ask some more questions in the follow-up session. Similarly, I expect some other intriguing work from our next presenter, Dr. Li Chen, who is a graduate student at the University of Washington.
Hello everyone, I'm Li Chen from University of Washington. I'm a PhD student in the Department of Electrical and Computer Engineering. I'm interested in using image processing and artificial intelligence tools to help medical research. Today, I'm going to share with you our recent progress of using an artificial intelligence tool, which we call FRAPPE, on popliteal vessel images analysis from a large data set. Atherosclerosis is a common vascular disease that cholesterol plaques are built up in the wall of the arteries, causing obstruction of blood flow. Our circulatory system delivers blood to all anatomical regions, so atherosclerosis is known as a systemic disease. In previous research on vessel wall, people are focusing on carotid and intracranial arteries, which are more related with cardiovascular disease. But recently, we found the popliteal arteries visible from the MRI scan of the Osteoarthritis Initiative dataset very interesting. OAI is a large study designed for osteoarthritis research with almost 5,000 subjects scanned for up to 8 time points for the knee. But good news is the OAI dataset is publicly available. For people doing atherosclerosis and vessel research like our group, acquiring a dataset of similar size is never feasible. We are excited to find that the OAI is a hidden treasure for vessel research. From the 3D data sequence of the mRNA scan from OAI, the vessel wall boundaries are clearly visible due to ideal blood flow suppression, high resolution, and large coverage. So vascular features such as vessel wall thickness are quantifiable for cardiovascular research. In addition, complete clinical data was collected in OAI. Traditionally, experienced vessel wall reviewers need to draw vessel wall contours manually to acquire quantitative vessel wall features to analyze the images. However, this approach would take 67 years to finish the review for all 3.5 million images in OAI, but this is what AI can make the work possible. We expect an AI solution to automatically locate artery region in the 3D image space, then segment and quantify vessel wall features with high accuracy and short time. Meanwhile, not many annotations are required to train a robust model. We developed fully automated and robust analysis technique for popliteal artery vessel wall evaluation, which we call FRAPPE, to analyze the whole OAI dataset. We identify artery center lines with a novel artery detection and track refinement approach, and then segment vessel wall contours along the center line for quantitative measurement of vessel wall features such as mean wall thickness and lumen area. No human interventions are needed in FRAPPE, so we can bring down the processing time from 4 hours to less than 8 minutes. With parallel processing, we analyze all the OAI images within 2 months. To solve the challenge for artery localization, we borrowed the object tracking idea from Computer Vision Society. By considering the axial direction as the time axis of videos, popliteal artery can be robustly localized through the tracking by detection approach. For accurate vessel segmentation, images are converted in a polar coordinate system for segmentation to ensure boundary continuity and avoid impact from the neighboring artery. To minimize human annotations, transfer learning approach is used to train the segmentation model from a pre-trained carotid model. In addition, badly segmented samples are picked out for annotations for additional training to further improve the segmentation performance. Here are some examples showing the robust and accurate vessel wall segmentation on some challenging cases, such as bifurcation and large clots. Some artery and vein may coexist, but FRAPPE can select the correct target for segmentation. With FRAPPE, there are many potential contributions can be made to the medical society. From the clinical perspective, FRAPPE can be applied to knee scans to provide free vascular measurements on top of knee diagnosis reports. When plaques are observed, patients can be directed to have a more comprehensive vascular MRI scan on carotid or intracranial arteries. For research purpose, FRAPPE achieves the workflow equivalent of 67 years of vessel reviewer by exploring tons of vascular features with existing clinical features in OAI, such as cardiovascular risk factors, physical exercises, and state of diabetes. Vessel features can enhance our understanding on atherosclerosis and vascular disease. OAI and FRAPPE facilitate many interesting studies, which are usually limited by data size, such as characterizing vessel remodeling pattern for popliteal arteries. Through hundreds of thousands of vessel wall measurements, we find lumen size increases with enlarging vessel wall thickness until a turning point, then reduces its size with overly thickening vessel wall. The deep learning model using FRAPPE is not a black box. Through visualization of embedding features for the popliteal images, we can identify plaque patterns, such as what shows here. Normal and plaques are formed in 2 clusters. Here's a list of awards and publications related with this project. This project is not possible without the involvement of all the people with different backgrounds. We also would like to acknowledge the support from AHA and NVIDIA. I think 3 components are needed for impactful research in medical imaging: ideas, data, and techniques. Usually, it's hard to find all 3 components for your project, but usually data is the main obstacle for our research due to the expenses of medical scans and data availability. From our research on the OAI dataset, we find it is an easy solution to explore existing large datasets from another angle. Fortunately, with the help of artificial intelligence, previously impossible tasks are being made possible. Supported by large and automatically analyzed data, we can explore many creative ideas for advancing our knowledge on medical research. Thanks for your attention.
Okay, thank you so much, Lee. That was fantastic. I'm very jealous of your data set. So we're going to transition here. That was the last of our invited junior investigator presentations. So we're going to have another Q&A session with all 5 of those presenters, as well as Dr. Blumke, who will join me for this session. So again, I would encourage you to type questions using the Q&A function in Zoom. You can see that Q&A tab at the bottom on the control panel within Zoom. And I'm going to do my best to try to consolidate these questions. I've got a few here for Nan Wang from Cedars-Sinai and UCLA. This is from Ed DeVella, who says, very nice talk. How long does the reconstruction Q-match take? And do you have any concerns with motion and pulsatility?
Okay, so thank you very much for the question. For the reconstruction of Q-match, for now, we still have to do the offline recon. We copy the raw data from the scanner, and the offline recon takes about within 1 or 2 hours. So depending on the computer power. And yeah, motion actually is like a big problem during the scan, because the entire scan is about 8 minutes. Actually, we do have some motion correction methods incorporated into this framework. So that's based on the multitasking framework. So we detect the bulk motion, remove them, and then interpret it back in the multitasking framework. And that can highly improve the image quality. Yeah.
Great. So another question while I've got you on the camera, from Dr. Parker. Were you surprised that in 39 patients with 53 plaques, only 1 had intraplaque hemorrhage? That seems low based on our experience.
Yeah, that's true. So I guess that's kind of based on this the truth of this patient cohort. So we performed this patient study in Korea. So perhaps based on for example, different races, and because this is just a pilot study, so maybe patient with some maybe just mild level of stenosis would be included in the study. So I think that's why there's only 1 intraplaque hemorrhage was in this patient cohort.
Do you have any more details on that cohort? Were they symptomatic, and were there any stenosis inclusion or exclusion criteria?
So the inclusion is just based on the ultrasound. If there's a stenosis on the ultrasound, the patient will be included in the study. And this patient should be with the symptoms, but maybe not very not very serious symptoms.
Okay, thank you. Okay. Okay. So we'll stick with vessel imaging. I have a question for Li Chen. What sequences are included in the OAI data set? And then you mentioned having full clinical data. Can you expand on that a little bit more, specifically with respect to cardiovascular risk factors and maybe cardiovascular events, outcomes data? Any of that available?
Yeah, okay, thank you for the question. So actually, the OAI study is not previously designed for osteoarthritis work. So we just find this data set which is suitable for our work. So there are multiple MR scans available in the data set, but after our examining, we find the DES, the double echo steady state sequence, which is best suitable for our vessel wall research because of the reasons I presented in the presentations. So finally, we use only the DES sequence for all our data. And for the clinical data set, I think the original purpose is not for cardiovascular disease, but it shares many of the common things that we can use. For example, how many people are finally dead, and something like that. And by correlating the vessel wall information with this clinical information, it can help us a lot to further our understanding of how these factors are correlated with each other and enhance our understanding for the atherosclerosis. Yeah, thank you.
Yeah, thank you. Another follow-up question for you. How much pre-processing of images do you need to do before applying AI to vessel tracking?
So actually our method is called fully automated. So that means nothing needs to be prepared. Everything is handled by this FRAPPE model. So in that image processing part, I think the only thing we need to do is to rescale the image intensity into a common range, and all the others are handled by AI.
Wow, great, thank you. Try to consolidate by presenter as best I can. A question for Olivia from Sarah Johnson. She said, great talk regarding the void volume decreasing over time. How is it confirmed that the mesenchymal stem cells were being cleared from the injection site rather than just the SPIO agent? And is cell death required to clear that agent?
Thanks for the question, Sarah. Can you hear me all right?
Yeah.
Okay. Yeah, it's a pleasure to be here today. So thanks again to Utah. To answer your question, there is really no evidence for the iron being expelled from cells. So really whatever happens to the iron within the labeled stem cells reflects what's happening to the cells. So the predominant mechanism that's happening is these stem cells are dying off, and in that process, they release their iron. So in that way, then the nearby immune cells will take up this cellular debris, including the iron, and clear it from the site. So I hope that answers your question.
Great, thank you. Question I had also for you was, what is the biological half-life for the SPIOs in those stem cells? Typically, these tend to lose contrast over time, and the labeling approach to track them in vivo can be limited in some settings.
Right, so it's a little bit different to think about the half-life of the iron in cells versus just the half-life of the iron itself if you were to inject it intravenously. So those are two different questions, but in the cell, for the most part, as I just mentioned, it's retained within the stem cells. And what could be happening in some situations is that with rapidly dividing cells, that iron becomes diluted between the cell progeny. And so really what that would cause in our images is that we would be underestimating the number of cells. But for our situation here, we really made no effort to make these cells survive. Most of them die off anyways. So what we're not really expecting much proliferation. And so this type of cell tracking technology is really good for those types of cells. So cells that might be terminally differentiated, that they aren't really dividing much, that kind of thing.
Great. Another follow-up question to that is, do you have an idea of what volume or percentage of the cells need to survive to deliver their therapeutic effect? And I suspect that might be a hard question to answer with just one, depending on your effect that you're looking for. But have you considered using these techniques to try to help obtain those answers?
Yeah, that's a great question. And I think there is no answer to that. We wouldn't know the answer to that. It's going to also vary a lot between patients, what works for one person versus another. Also, what kind of stem cells are administered in what situation. So yeah, we can rely on these imaging techniques, not only in clinical studies to monitor what's happening to these cells and inform treatment decisions, but also in preclinical studies. We can look at optimizing these cell therapies, what works and what doesn't, what improves the stem cell survival in animal models before applying these to humans too.
Great. I got several questions about MPI, the iron imaging. That's pretty hot. Is this only a tool for preclinical imaging? Can it be applied to humans? How many are out there? I think several of us have never heard of that before today.
Yeah, right. It is a very new imaging modality. There was, some scanners made in different labs, made by grad students over the last decade or so. Now they're available commercially, and so there's a handful of them in North America, and we just got the first one in Canada, in London, Ontario. So it is a very unique imaging modality in the fact that it directly detects the iron oxide agents, and everything is still under development, including these nanoparticles, because right now we've just repurposed the nanoparticles from MRI to be used for MPI. So there's really a lot that can be improved on as well. In terms of human scanners, there are a couple groups that are working on various MPI systems to be used with humans, for example, a head scanner, and eventually we're hoping that will be fully scaled up.
Great, that's very impressive, thanks. Dr. Blumke, I don't want to neglect you and your expertise. Please feel free to chime in if you have any questions.
Could I follow up with Olivia on that question? Has MPI led you to any insights so far as to where's the iron going? So, the iron eventually kind of dissipates or decreases over time. And one question is, what has happened to that as a different state or something? Any insights so far with MPI and what's happening to the iron?
Yeah, we're learning so much with this new technology, mostly because of the iron oxides creating a void in MRI. So for example, imaging in the lung, in the bone, things like that has been very difficult. And so with MPI, we can start to do things like that. So it's been fun. And our lab actually just put out a preprint on our perspective on MPI for cell tracking. So you can look for that too for more.
I had a question for Shadi about her work on gastric cancer. And, the response using the hyperpolarized equipment is incredible and very, very rapid. Could you kind of explain to us how how that could translate? Is this something that would be used perhaps very early in therapy to see if this person could avoid the 2 months of not successful therapy, or are we at that point yet where we're really trying to determine certain tumor types, perhaps using this sort of technique, or where do you see that going?
Hi, Dr. Blumke. Hi, everyone. Thank you very much for the invitation. So as you mentioned, the MR spectroscopic imaging is evolving very, very rapidly. And as you know, there are about 30 to 40 centers in the whole world that are using the MR spectroscopic imaging. Some of the centers also have the human polarizer. We just received our preclinical polarizer, and we'll have the human polarizer very soon. So in terms of how it's going to work, it looks like, based on the literature so far, there's so much work still ongoing in the preclinical setting. And a variety of tumors have been already evaluated, in addition to other conditions such as inflammation or myocardial perfusion imaging. This method has been tested on many types of tumors so far, and also different types of metabolites have been evaluated for evaluation of early response. And there has been really, really great amount of articles in the past 2 years about the early treatment response, and this would be really, really tremendous. It would be very helpful to the clinicians if we can basically translate it and have this method in addition to a standard of care MRI or PET-MR, to basically have that as an addition to our anatomic imaging to help the clinicians with early evaluation of response. I think the future is really bright in terms of how fast we can have it nationwide and worldwide and use it in our clinical practice. I think we're still learning so much about it, but the knowledge has been very growing, and it's been very fast. So I'm really hoping that in the next few years we can have a lot of great data that we can basically translate it in our clinical practice.
So one little follow-up on that. Do you have any insight as to how the technique scales to larger animal models, and the SNR as the size of the patient or size of the animal gets larger? Is the scaling factor going to work for this technology?
I think so. Well, I'm not the best physicist to answer this very well, but yes, I'm very hopeful, because the amount of work on like in the scale of mouse, rat, and also human has been really great. The coils are obviously very important, and I know that there are a lot of companies right now that are tremendously working on this. So I'm really hoping that the SNR wouldn't be a huge issue. There are specific codes right now for a lot of brain imaging, upper abdominal imaging, and prostate imaging. So as the time goes, we need a lot of technology to help us to make sure that we get great SNR.
Great. Matt, can I go ahead with one more to Jessica?
Yeah. Please.
Okay. Jessica, the progress in the field does seem to be moving towards not only an issue of killing the tumor, but the stimulation of immune response. And you showed really elegant ways to show that immune response. And the examples you've shown, it was this uniform line or band. I'm wondering if how you're going to look at differences in early tumor recurrence, juxtaposed perhaps next to the tumor response. Are you going to do imaging of both the tumor and the immune response? Or how are you going to try and tease out what causes the recurrence, or maybe success or versus failures at the immune response or lack thereof versus the tumor aggressiveness?
Hi, thanks for the opportunity again to present my work here. So that was a good question. So for this first work, firstly, we tried to establish those immunoprobes, especially the one with gadolinium labeled antibodies, in a reproducible way. So the next step right now is to use the same set of techniques to label the antibodies that will target T cells. So that's like our main and the next goal is to be able to image T cells in an inflammatory tumor microenvironment. And once we achieve that step, the way we're going to see like if there's going to be a response or not, that would be like the immune profile that we could be imaged prior to treatment. So let's say if a tumor is considered immunogenic, meaning there's a lot of T cells present, there's a higher chance that that tumor in particular will respond better to immunotherapy, for example. So in this way, the main priority of this work is just to be able to identify those types of tumors and the immunophenotypic profile prior to treatment to sort of like map out or segregate which is the tumor that's more likely to benefit from therapy than the one that's not. So I hope I kind of like answered your question.
Yeah, it's really one of the newer concepts, I think, in RFA, whereas individuals, the interventionalists thought you just have to burn it and kill it. And you see these very interesting immune responses developing in patients who are successfully treated or not. So this starts to get at that question, if you can go really beyond just imaging the tumor all the time, but the response to therapy.
Yes.
And how does edema confound some of those analyses? I guess you really shouldn't be too affected by adjacent edema, I suppose, right?
Well, yeah, there is the fact of what they call the pseudoprogression, which is like if the tumor itself, it's like it's responding or not. But in our case, it's like we're essentially trying to image in a sophisticated way those immune cells. So if we're able to locally detect and prove that there is a precise imaging of those immunocells, we can sort of like distinguish between a pseudoprogression or the response of the tumor.
Got it. Okay.
I had another question for you, Jessica. Have you done any looks at parameters at the time of treatment specific to the ablation and correlating that with the outcomes on the surveillance imaging to see if there are certain variables that need to be controlled or modulated by the interventionalist to achieve the best outcome?
Well, not yet, because this, as I said, this set of experiments is just to establish those immunoprobes. So we're not ablating tumors, we're ablating normal liver.
Okay.
And the fact that we're ablating normal liver, it's because we have noticed that upon ablation of a normal liver, we induce a local immune response towards it. So, and the immune response is essentially characterized by the healing process. So because we induce a local inflammatory process following RFA. And we use that as a platform to image those macrophages and build those immunoprobes in a reproducible way. So we're not like ablating tumors yet.
Gotcha. Thanks. I had a question in the Q&A for you that I didn't want to neglect from Allison Payne. She's asking, is the ultimate goal really to have a marker that could identify treatment outcomes at the end of the therapy? Is 1 week follow-up considered standard for immunotherapies? And is this something you could potentially use as a marker for whether or not you need to ablate more, perhaps sooner?
Yeah, one of our techniques that right now we're trying to develop is we're trying to image the pH, local pH. So in our previous work published in the radiology paper in a VX2 rabbit model, we were able to, well, we didn't use RFA essentially, but we used TACE. And we were able to show that upon TACE, there is a changing in the pH. And we also co-localized those immune cells in the peritumoral area that were tagged with the HLA-DR gadolinium antibody. So the set of this work in the future is to try to essentially image this immunometabolic crosstalk that might be reflective of the tumor response post local regional therapy. So essentially we're trying to combine, let's say, imaging the local pH with the immune response following, let's say, RFA or TACE and so on. But in mice right now, we're just focusing on RFA.
Great. Dr. Blumke, any others? I think I've gotten through the questions that were written to me.
Yeah, no, those were beautiful presentations and really good answers in addition all around. People know.
I'll second that, definitely. So I think with that, we'll wrap up our first day of Imaging Elevated then. I want to thank everybody who participated. I want to thank Dr. Blumke for participating today and also for your leadership in our field, and then also for our junior investigators. I think the future is quite bright for imaging research. So it's been a fun afternoon. So don't miss tomorrow and Friday at the same time, 3 p.m. Mountain, 3 to 5. We have more exciting content. To get the full details of our agenda, please visit imagingelevated.org. And with that, I think we'll close out day one and look forward to seeing you guys all virtually tomorrow. Take care.
Thank you very much.
Thank you.
Thank you. Bye-bye.